So I'd like to talk about the STATIC trial, and this is asking a slightly different question to the ones that Tao just described. So, as some people will be aware, there's many now excellent treatments available for CLL, and one particular group of drugs we call BTK inhibitors. And that's basically tablet-based therapy, which includes ibrutinib that we just heard about, but also another tablet, acalabrutinib, and a newer one called zanubrutinib. And these treatments are highly effective in the treatment of CLL. And all these treatments, the standard of care is that you take the treatment, and as long as it works well, which it nearly always does, and as long as you don't get side effects, then you continue with the treatment long term. And these drugs have been around now for getting on 10 years, and there's certainly people who have been on ibrutinib for that period of time. But it's sort of becoming clear that maybe some people who respond well to these treatments, maybe there's scope to stop the therapy or interrupt it and have a whole different treatment. And so the STATIC trial is sort of thinking about questions around how long do you need to continue these highly effective therapies for? Could I have the next slide, please? So the rationale is do we really need to continue with these effective therapies long term? So the upside of staying on treatment is that the treatment suppresses the leukemia. You've often got the security of feeling that you're on ongoing treatment. But the downside is that it is a treatment, and even though it's effective and well tolerated, it'll still have side effects. And side effects that sometimes people can have, it can sometimes cause problems with blood pressure, heart rhythm problems. People can just feel a bit generally less well, a bit sickly on it, and other ways it can affect the health. And there's also a sort of a potential concern is if you're on a treatment continuously for a cancer that's suppressing that cancer, then if somewhere in your body there's a few cancer cells that are resistant to the treatment you're giving, if you continually carry on with the treatment, it sort of gives the chance for these resistant cells to sort of to grow at the expense of cancer cells that are susceptible to treatment. So it's suggested maybe that if you give the treatment to suppress the disease, get into a remission, which means everything gets better, and then stop the treatment for a period of time, keep a close eye on the disease and the person, then that may avoid this selection out, this sort of selecting out of more resistant leukemia cells. So that's sort of the rationale really is do we need to carry on with these therapies long term? Can we safely interrupt them, minimize side effects, give people a period of time, possibly a prolonged period of time, without having a continual reminder of having to take the tablets every day and whatever feelings that may bring back? And also, can we prevent the emergence of resistant leukemia ultimately? So yeah, so the hypothesis is as stated here really. So does this sort of stop-start intermittent approach in people who are doing well with treatment, for people treated with the drugs called ibrutinib or acalabrutinib, will that lessen the chance of the disease ultimately becoming resistant to therapy? And will it improve people's quality of life? There's also the additional benefit, which is not the primary concern, but is always of interest to the NHS, is could this overall reduce the cost of these medicines to the NHS without compromising on people's care and quality of life? So this is a sort of flow chart of the trial overview. And in essence, we're looking for 800 people to take part in the trial. And that number's derived from assumptions around how effective the approach will be. And half the people within the study will basically just carry on with their allocated therapy as normal. So you'll be approached by somebody like myself or one of the research team and say, you know, you've been on ibrutinib or acalabrutinib for a while, or you were previously on ibrutinib in FLAIR. Would you be interested in this study? And after thinking it through and reading the information and talking to whoever you want to talk to about it and talking to the clinicians or the research team again, you agree to take part. Then what happens? You sign the form, all your details go off to the Leeds Trials unit, and and then there's a computer. The computer's got like a metal arm sticking out of it, and the metal arm flips a coin. And then the trials team look at which way down the coin comes, and that then decides whether you get continuous treatment or intermittent treatment. It doesn't really do that. Anyway. And so half the people will just carry on with the therapy as normal. They'll carry on with the ibrutinib, acalabrutinib, as you would do ordinarily. But the other half will get randomized to an intermittent treatment approach. And this means that if you're in remission and your blood counts are all really good, the ibrutinib or acalabrutinib will stop. You'll be kept a close eye on, be monitored closely every 3 months or so. And at the first sign, the first flicker of the white count going up, you'll go back on the ibrutinib or acalabrutinib for at least 6 months. And then if the white cells go back to normal, the treatment will be stopped again. And you'll go on like that with that stop-start approach, really for as long as the trial runs, or until there's such time that either the disease needs treatment with something different or something else happens. And people in the trial are kept a close eye on. They're seen by a member of the research team every 3 months. There's a blood test done. Someone like myself will do a physical examination. There's all sorts of other assessments that are really called quality of life, which is really interested in how do you feel? Do you feel better, worse, no different? And the trial's primary outcome, which means what it's trying to show is how long before that treatment approach fails. So how long, if your ibrutinib or acalabrutinib is continued indefinitely, how long until you have to stop and switch to another treatment? And likewise with the intermittent approach, how long you go on until you stop and then have a different treatment. And the trial is also looking at some other things such as overall survival, side effects, how effective the treatment is in terms of NHS costs, how you feel in yourself, which is very important, obviously, how long it takes before you need another therapy. So the trial needs about 800 people to take part in it, and we need that many so that we can be confident that whatever result comes out of the study is an accurate and a true one. And we anticipate that a lot of the patients going into static will be taking ibrutinib that they were previously given during the FLAIR study, but other people will be entering the study having been treated with ibrutinib or acalabrutinib from standard NHS sources. And there'll be a small number of people going into the study who are on ibrutinib and who have disease that has responded to the ibrutinib but doesn't fulfill the entry criteria into the trial, and they'll be allocated to continue the ibrutinib, and that'll be called the clinical need cohort, and that group of people will be monitored closely to see how they get on with the continued ibrutinib. So these are people that can possibly go into the sort of static study. So there's people who've been on ibrutinib for 6 years in FLAIR. The signs that the CLL is a bit active. They don't fulfill the entry criteria to static, but still carrying on with the ibrutinib still sounds like a good idea. So that can be done in what's called the clinical need cohort. And then other people who received ibrutinib within the FLAIR study, ibrutinib or ibrutinib rituximab was for a maximum of 6 years. So people who've reached that 6 years point and then who wish to take part in static and either continue the ibrutinib or start and stop, they can take part. Initially, static was designed with ibrutinib in mind, but we're in the happy situation that there's new treatments coming thick and fast for CLL. So from the study, from static being designed to implemented, acalabrutinib came along. And so the team have managed to incorporate acalabrutinib into the study by discussing that with the people that pay for the trial and also the people that pay for the acalabrutinib. And to go in the study, you have to have a CLL that's deemed to be in remission. So that means that you're well, you've no enlarged lymph nodes, and that your blood count is essentially normal. So the trial's going on, the trial's going forward. Recruitment is probably not where it should be for a variety of reasons, and we've found that sometimes when people are approached to take part in the static study, people feel well on the current treatment, which is great, and they're actually having no side effects, and taking the medicine is not a burden to them. and people feel they'd rather carry on with that, which is fine. Delivering any sort of research, you have to have people to actually do it. You have to have people to come and talk to you and fill out the paperwork and do the work. And a lot of NHS hospitals are struggling to identify enough staff to do that. I think it's probably fair to say that the research question in static is a little bit harder to sell than in FLAIR. So in FLAIR, it's you get this, that, or the other treatment, and one may or may not be better. In static, it's sort of almost the opposite. You know, you're on a treatment that's working, and you're sort of de-escalating it. But it's a valid and important question, and one that's been asked actually in other blood cancers. And the trial, because the treatments work so well, which, as I said, is great, but the problem with that is means you need to follow a lot of people up for a long period of time to really work out if one approach is better than the other or if they're both equally valid. And feedback we've received about from patients about why they would or wouldn't want to take part. So it often feeds into people feel safe and secure on their existing treatments. A bit of uncertainty around what may happen when treatment's stopped, and there also is a commitment. So some people, some centres, ourselves included, people who are stable and well on acalabrutinib or ibrutinib, and possibly who live some distance from the centre, can be managed remotely by telephone or video, and medicines can be dispensed remotely. But for a clinical trial, you've got to come into the hospital and hang around and wait for me to finish my coffee and finish doing what I'm doing to see you. There's a lot of hanging around, a lot of waiting, traveling, blood tests. So it's a bit of a faff. But to safely deliver a clinical trial, you probably really do need to have people in front of you and do all the various assessments. So we're really wanting to answer this question. We all think this is an important and valid question. I think this trial is asking the most interesting and pertinent question with regards to CLL treatment. The pharmaceutical industry are very good at producing really, really good, effective medicines that get better with each generation. These medicines are nearly always approved to be taken potentially forever. And it may well be that's the most effective way of doing it. But no manufacturer that's making money from their product is interested in doing a clinical trial whereby we're essentially stopping or reducing the amount of drug. So there's really only the United Kingdom, the NHS, and the team in Leeds that are really trying to face up to this, and ask this question: well, can we safely interrupt or stop these medicines in some people? So how can we improve this? Well, we need to reach out to our colleagues. I think people like myself and TAL that treat CLL in the UK are very engaged with research, and we really understand the importance of research because we can clearly see over our careers how far treatment for this disease has come. We need to reach out and do more education and presenting of this, and Tal's a busy man. He's traveling all over Britain and the world, sort of presenting FLAIR, presenting STATIC. So everyone's doing what they can. We're trying to open more centres. We're trying to make it as easy as possible for centres to engage with us. And in terms of reaching out the most important group of people, which are yourselves, we try to sort of maintain information through sessions like this. There's a website. Clinicians like myself have got a duty to try and explain this in as clear and unbalanced way as possible. And also with involving people like Hilary and John and others in actual oversight and delivery of the study. So I think that moves on to where we're actually at.